Hello, this is Kathy Bush, and welcome to the DandleLION medical webinar titled Debunking NICU Myths and Evidence with Evidence and Finesse. We have two faculty presenters this morning, Carrie Ann Waitzman and Shannon Usher. Carrie Ann has been a neonatal therapist for 33 years at a level 3 NICU, where she assisted with the 60-bed single-family room NICU design, initiated and maintains the developmental care and therapy program, and serves as the nursery's developmental specialist. Carrie Ann is a certified neonatal therapist and is certified in NDT, NIDCAP, and neonatal touch and massage. Shannon has presented nationally on numerous topics related to neuroprotective caregiving in the NICU. She's a clinical consultant and CE administrator with Creative Therapy Consultants. Shannon has completed developmental follow-up assessments for National Institute of Health Research Study, served on the March of Dimes Program Services Board, served as an expert for reliability testing of the neonatal eating outcome assessment, and volunteers with the Junior League of Colorado Springs. Now, Carrie Ann wasn't sure that she was going to be able to get off work, so we have recorded this webinar. Carrie Ann and Shannon are both on live, so if you want to both say hi before we move over.
Hi. Hi, everybody. Thank you for joining us.
So we'll be back at the end, and we're going to turn this over to the recording now. So thanks everyone for watching.
Thank you so much for that introduction. Carrie Ann and I are both very excited to be here with you today. But before we can really delve into the content of our presentation, we have a few matters of business to get through. First, you can see our disclosures listed here. You can see that I'm a consultant with Creative Therapy Consultants, and Carrie Ann is the president of Creative Therapy Consultants. She's also the founder of the Neonatal Touch and Massage Certification and on the Pampers Womb to World Advisory Board. She also serves as a member on the March of Dimes Program Services Board. Next are the objectives that we're going to focus on during our presentation today. You can see that we're going to focus on the 4 steps in the path to action as it relates to crucial conversations. And we're also going to talk about 3 traditional NICU myths that, believe it or not based in current evidence. So let's get started. Have you ever given any thought to where myths come from? Do they come from really cute little babies daydreaming on pillows about where baby oil must come from if olive oil comes from olives? Or do they come from well-intentioned people who are taking the best information they have access to at the time and creating a plan of action based off of that? The truth is, I have no idea where myths come from, but what I do know is that myths surround us every single day. They surround us in our day-to-day life, and yes, believe it or not, they surround us in the NICU. I want to ask you a question. What is the tallest mountain in the world? My guess is most of you are thinking Mount Everest, but the truth is Mauna Kea is the tallest mountain in the world. Now, I know some of you are probably thinking, well, she's wrong, and that's embarrassing because she's presenting on a national platform. But that's the funny thing about myths. We come to believe them as fact, but they're not. And often there's evidence to say otherwise, or perhaps there's no evidence to support the myth whatsoever. Carrie Ann and I have the incredible opportunity to offer neonatal education and mentorship around the country and around the world. And in having conversations with brilliant people from all over the place, we found that the same caregiving practices were being brought to our attention, and many of those caregiving practices were big, giant myths. They weren't based in evidence, they weren't based in fact, and yet they were prevailing around the world, despite the level of acuity, the patient population, or the location that they were. And that's what really inspired this presentation. We recognized when putting this presentation together that there would be many components that came into it. One, of course, being evidence, because evidence matters. It's what drives everything that we do every day. So to that effect, for those of you that have missed the last 2 minutes of what I've been talking about because you were Googling tallest mountain in the world, Mount Everest is anecdotally referred to as the tallest mountain in the world, standing at 29,000 feet in elevation. But Mauna Kea in Hawaii is 33,000 feet tall. However, most of its landmass is underwater, so it only stands at 13,000 feet in elevation. Again, evidence matters. However, we also recognize that we're all intelligent people, and many of the meta-analysis or randomized controlled trials or p-values that we would share or discuss with you, you'd already be familiar with. And yet, as familiar as you are with these studies, many of these caregiving practices still prevail in your NICU. And there's another piece that goes into changing caregiving practices, and that's the finesse. That sometimes it's more than just the evidence, that we can present in every staff meeting or play an integral role on every policy and procedure, and that we can make poster presentation after poster presentation. And yet, what really drives the changes are the individual conversations that we're having on a day-to-day basis with our staff and NICU parents, and that we're really facilitating change from the inside out. So to further highlight that, Kara Ann and I would like to role play a common interaction in the NICU between two staff members.
Hey Shannon, how are you today?
I'm fine. I had a crazy morning trying to get the kids to school. My husband's out of town. My in-laws get in town tomorrow. So my whole house needs to be cleaned up. It was just a rough morning.
Okay, well, I can fill you in on Emmy.
Just tell me about last night. I've taken care of Emmy. I take care of her all the time, and I had her for the last 2 days.
Okay, well, Emmy's 35 plus 2 today. She's up 30 grams from yesterday. She's still on her low-flow nasal cannula without any vents, and she's getting 24-calorie Enthymil AR, 65 cc's every 3 hours, and she took 15, 30 gavage, and then 30 last night.
Really? She always takes all of her feedings for me. And why is the head of her bed not elevated anymore?
Oh, well, because I lowered it when I came in last night.
Why would you do that? She's a refluxer. She spits all the time. She's miserable.
Well, actually, I've read a lot of research articles, and there's really no research to show that elevating the head of the bed helps with reflux.
Here's the thing. People who do research aren't clinical. They don't get it. You should have seen her yesterday. Spit everywhere. I had to change her whole bed. I know you're newer, but I've seen it for years. Keeping her upright is the only way to help.
Well, actually, even if you read the AAP statement about reflux, being upright doesn't actually help. And there's other articles that say that sometimes we don't think the babies are refluxing, but really they're actually not.
I don't have time to read those things. Days are way too busy for that. I have a 4-baby assignment today, including one baby who has a swallow study and rounds, and it's bath day, and none of my parents are coming in to help.
Well, last night was crazy too. We did have 3 admits. And by the way, Jody shared in staff meeting a few months ago that our policy was updated. We're actually not supposed to elevate the beds anymore.
Maybe she did, but we get so much staff information in that staff meeting, it's hard to remember anything. I've been a nurse for over 20 years, and I know that elevating the head of the bed is the only way that's going to help. And it's just the way we've always done it. Anyways, thanks for the report. I need to go get a report on my other babies. Go home and get some sleep. I think it's fair to say that all of us have been part of an interaction or witnessed an interaction that in some ways reflected the conversation you just heard. You'll notice in the conversation that Kara Ann was smart. She was familiar with the evidence. She was familiar with the policies and procedures that guided her NICU. And yet, she was completely ineffective in making any type of change in that situation. For this exact reason, it's why we chose to start this presentation talking about the finesse, the pieces that are required to really debunk these myths. That brings us into the topic of crucial conversations. Crucial conversations are conversations that have a couple components that come together. The first one being opposing opinions, when we're not seeing eye to eye. I've never met 2 people in the NICU who don't see eye to eye. Have you? The truth is, when I talk about opposing opinions, many of you may think of a specific person you work with. I want you to keep that person in mind as we talk through these concepts. Strong emotions are another component of crucial conversations. When you're taking care of a 2-pound baby, emotions run strong. When you have families in times of stress, emotions run strong. Medical emergencies. When you have a neonatal intensive care unit that is full of passionate people, they're emotionally charged. And all of these will impact these crucial conversations. And lastly, there are high stakes. I can think of very few environments in the entire world that have higher stakes than the NICU. The thing is about these crucial conversations is they have a significant impact on the lives of the babies that we care for, and there's a significant risk for negative outcomes based off of these conversations. How do you know that you're in a crucial conversation? What does that feel like? There are actually different signs that we emit as a human being that help us recognize when we're in a crucial conversation. One of them is physical signs. When we're in a crucial conversation, oftentimes our heart rate goes up, or our breathing patterns may change. We may get a tightness in our stomach or even a knot in our throat. Those are all physical signs that yes, this is a crucial conversation. There are emotional signs. We may start to feel anxious, possibly angry or fearful. All those emotional components that help us recognize these crucial conversations. And lastly, we're going to have behavioral signs. We may act in a way that is not typical for who we are as a human being. So we may shut down. We may not say what we're thinking. We may stay in silence. Or we may start talking faster or raising our voice. You can imagine in the conversation that Kara Ann and I were having that we would have been experiencing many physical, emotional, and behavioral signs throughout that interaction. In fact, even just listening to it yourself, you may have seen those changes in your own body. Now, you may be wondering, what on earth does this have to do with me? Well, the truth is, crucial conversations happen everywhere. They could happen between you and your mother-in-law. They could happen between you and a physician while you're discussing the validity of integrating neonatal massage into the daily caregiving of an IUG or SGA baby who's not gaining weight well. Crucial conversation can happen on a committee that you're on or even amongst your own team. If you've got a former 24-weeker who's now 34 weeks, scoring 1s and 2s on feeding readiness, and you want to discuss how to delineate their plan of care. You may even need to have a conversation with your best friend at work. They're everywhere. And the thing is about crucial conversations is they can be planned to when you know that you're going to get into one, or you may be knee deep in before you even realize what's happening. That brings us into this model that's going to help guide us through crucial conversations and recognizing that before we even get into a conversation like this, we need to work on ourselves first. That we need to understand who we are as a person and the stories that guide our life. We need to recognize that the only person who can control you and how you react in certain situations is you. That we have a perceived perception of reality, and that perceived perception of reality is going to impact how we interpret situations. However, where I am versus where you are in our journey of life is going to be very different, and that the person we're engaging with is going to be very different, and that our perceived perceptions of reality are going to differ. As we have a better understanding of this and we've mastered this, we move into the conversation. And as you can see here, this brings us into the circle of silence and violence. And that comes back to that first objective that we talked about earlier, where we discussed the 4 steps in the path to action. So what are those? Within a path to action in any event that we have in our lives, we first see and hear what happens. Those are the facts. But then naturally, as human beings, we tell ourselves a story. When we tell ourselves a story in our head, that makes us feel a certain way. And because of those feelings, we act accordingly. When I think about that in the NICU, I think about walking into a coworker's room. She's taking care of a 30-week baby that's in an isolette. And I walk in and I see that baby supine in their bed with a neck roll. The baby's scapulas are retracted, their neck is extended, and in theory, that's been placed there for ventilation. And the story I'm going to tell myself may vary. So I see that neck roll and I'm going to tell myself, oh my gosh, this person does this all the time. Her caregiving practices are so old. And I know I just educated her as part of the developmental committee, and we just did an in-service at the staff meetings, and she sat in the back and she talked to her friends the whole time and didn't listen to a word I said. Now that's going to make me feel frustrated That's going to make me feel angry. And because of that, I'm going to act in a way that doesn't offer mutual respect. I'm likely going to be condescending. I'm going to potentially be rude, or I may just shut down and not say anything. However, if we rewind that situation and start back to the see and hear, so the same situation, I walk into a room where my coworker is and she's taking care of a 30-week baby that's in an isolette. I walk in, I see the baby supine in the bed with a neck roll. And in my head, I'm going to tell myself, you know what? I just did a bunch of education with the developmental committee in the staff meetings, and I know she was there. And yet, where did I miss an opportunity to connect with her during the education? Because clearly my education hasn't changed her caregiving practices. Now, how can I alter what I do to better connect and relate with her so that she can learn a better way to care for this baby? In telling myself this story, it's going to make me feel empowered. It's going to make me feel confident. And then I will treat my coworker with mutual respect and problem solving, where we're going to move into this pool of shared meaning you see there, because now we're sharing similar stories. As we then progress through the conversation, we'll move toward the conversation that we can now agree on a mutual purpose and move forward together. There's a few steps that you can keep in mind that are going to help you with these conversations. The first one being start with heart. So that means that we recognize that everyone that works in the NICU genuinely wants the absolute best outcomes for the babies and families they serve. That we need to have empathy for that, and that we start with a well-intentioned thought. That we need to stay in dialogue and keep the communication open. So that means that if you don't see eye to eye with the respiratory therapist that's helping care for your baby, and her shift ends at 3 o'clock, and you choose not to help mom get the baby out skin to skin with the respiratory therapist until 4 o'clock, that we're not staying in dialogue. That we want to keep it safe. You notice in the conversation between Kara Ann and I that Kara Ann mentioned the staff meeting and the policies and procedures, and she didn't keep that environment safe, which is not going to lead to a productive outcome. To not get hooked in by emotion. I'm sure none of you missed the comment that I had for Kara Ann during report about how the baby always eats all of her feeding for me. I'm sure we've all heard that before. It's easy to get hooked in by that too. And that immediately then skews the rest of the conversation. So to be conscious not to let those comments hook you in. That you want to agree on a mutual purpose, that you're going to separate facts from story, and that you're going to agree to a clear action plan together. Now that we've delved into some of those concepts, let's just jump into one of the myths that Kara and I touched on during our conversation. We found it very important as we were putting this presentation together to really get input from neonatal caregivers around the world to find out which myths and caregiving practices were really continuing to prevail in NICUs. So we sent out a survey and asked people to submit the myths that they wanted debunked. Overwhelmingly, elevating the head of the bed to decrease reflux was the #1 myth submitted. So we figured we'd start there. You can see the evidence here. Elevating the head of the infant's crib is ineffective in reducing gastroesophageal reflux and is not recommended. That's from the Task Force on Sudden Infant Death Syndrome. Additionally, placing infants on a head-up angle is a common initial approach to management. However, head elevation is ineffective in reducing acid reflux in older infants, and that's from the Committee on Fetus and Newborn. Truth be told, there's a ton of research we could have put on this slide, and yet we could think of nothing that more directly and succinctly debunked this myth than those 2 statements right there. But what about some of the additional finesse? Those other components relating to elevating the head of the bed? What other things might I be worried about? Well, first I'm going to think about their respiratory status. We know, both because it's stated in the research and because we know anatomy and how the lungs function, that if I have a head of the bed elevated and the baby falls to the bottom of her crib, it's going to increase her intra-abdominal pressure, and the ability for her lungs to fully expand and for her to ventilate well is going to be compromised. Similarly, with that increased intra-abdominal pressure, I'm going to put more impetus on the stomach, which potentially could cause more reflux in and of itself. Now I think about movement, and if that baby's potentially fallen to the bottom of the crib, or simply because she's on an incline and there's going to be an increasing gravitational pull on her lower extremities, she's not going to have the same amount of movement that she otherwise would if she were flat. Because of that, her lymphatic flow is going to be impacted. Her peristalsis is going to be impacted. There's a lot of other components that truly play into why we shouldn't be elevating the head of the bed. Now, sometimes the arguments are made, well, what can I do? One of those options would be to offer non-nutritive sucking during assessments or during NG feeds. There was a great 2018 article that was released that discussed how actually when we utilize a pacifier, it helps significantly decrease distension issues. When we think about holding and positioning, and we actually change our vantage point to think about positioning as more of a functional life activity. Now, this ties into the limited amount of research that does discuss the potential for alternative positioning, primarily referring to side lying or prone, that it may reduce the frequency or severity of reflux. However, the point is continually driven home that in order to consider side lying or prone positioning, that the ill effects of reflux must supersede the concern for sudden infant death syndrome. There was actually a summary released in 2018 by the North American and European Society of Pediatric Gastroenterology, Hepatology, and Nutrition that made a strong recommendation not to offer alternative positioning for babies. And this included side lying, prone, or elevating the head of the bed. However, if I get a baby out that's held skin to skin by their mom, where they're more than likely positioned prone, and that's a functional activity for the mom and the baby, because goodness knows there's a lot of benefits for that baby to be held skin to skin. And it could potentially mediate some of the issues that they're having with reflux. What a great life activity to help facilitate. There's one more concept that we want to introduce that's really going to help you facilitate true change in your NICU, and that's the idea of motivational interviewing. And this concept is important when we have to truly understand human beings and knowing that someone will never change because they're being told to change. However, we can actually help motivate someone to recognize the change that they need to make in themselves. So how would you go about doing this? The first thing you want to do is focus on developing discrepancy. To go back to the goal that you know your coworker has, that they want to provide the best care possible for the babies and families in your nursery. We need to help them recognize that the care they're providing isn't doing that, and then realize the discrepancy between what they want to do and what they are doing. You, of course, want to express empathy, that we understand where people are coming from and the decisions that they may or may not have made. You want to roll with resistance. I don't know if you noticed in the role play between Carrie Ann and I, but we were obviously not seeing eye to eye, and Carrie Ann put up a fair amount of resistance to anything I said. And simultaneously, I stood my ground and put a firm line in the sand. When I look back on that conversation, both she and I had a huge opportunity to both roll with resistance and express empathy for where each other were coming from. And then I want to support self-efficacy. As a person in the NICU, I don't want to go around completing tasks for other people, but instead I want to actually educate and provide them with the knowledge that they need to complete that activity themselves, to create an expertise, and then again, support that self-efficacy. A few skills that you can incorporate to really integrate this approach are things like open-ended questions. So staying away from yes or no questions, but instead things like, can you tell me more about that? That you want to affirm what your coworkers are saying and reflect on the conversations that you're having. Then you can summarize that conversation with your coworker and move forward with a mutual purpose, which is what we discussed earlier actually with those crucial conversations. So if we take just a second and reflect back on that role play that Carrie Ann and I had earlier, you can see how you may take some of these principles and make some small subtle changes in your responses that would completely unfold an alternative outcome. So now hopefully you have a better idea of what you can do as a neonatal caregiver to truly debunk these myths and facilitate change. I'm now going to hand it over to Kara Ann, who's going to go through even more of the myths that we found here in the NICU.
Thank you, Shannon, for getting us started with 7 steps with crucial conversations, motivational interviewing, and starting us with that first myth about GER. I wanted to mention before I move forward and talk about a lot more NICU myths, that we do have a supplemental handout that will be available to you. So at the end of this presentation, we will give you a link that you can download this handout. The reason why we've done this is we just literally don't have time to talk about all of the evidence that is available to help debunk these myths. So we've created this handout for you that will allow you to listen to this presentation and take away the take-home messages for now, and then you can obviously go back and download this handout, which will give you a lot of valuable information to have these crucial conversations with your team back in the NICU. So the first myth we're going to debunk with evidence and finesse is that organic or natural products are just too expensive. Now, this is not a myth from the NICU dark ages like most of the others, but it has become a common in the past few years as neonatal massage is being used more and more in the NICU, and since society as a whole has taken a shift toward natural products, and the more specifically being aware of the cumulative effects of toxins over a lifetime, which can certainly impact the fragile infants that we serve. Now let's look at the evidence. This article by Brower, Treves, and Bums in 2015 was published in Joggin and identified as a QI project looking at providing green products for maternal infant dyads. The QI project was initiated as just the right thing to do when going green for maternity infant dyads, since it's now known that a wide range of toxic chemicals have been found in the umbilical cord of newborns, indicating that the potential for health risk from chemical exposure actually begins in utero. So they identified the hazard rating of current prenatal and postpartum products, selected chemical-free ones, provided educational in-services to staff and to patients, and then they monitored their patient satisfaction scores as well as the financial implications for the project. So this study was actually provided as a poster at a national nursing conference where they identified $12,000 cost savings over 1 year. They also found that 71% of the patients were very positive about this switch to chemical-free products. So this whole idea of that green products being less expensive is really debunked right here in this one article. Now there's other myths related to natural and green and organic and what all of those things mean as well. From a finesse standpoint, I think it's important to look at some other resources such as donoharm.org, which has toolkits, audits, checklists, and even some educational modules related to all of this. Of course, the A1 4th edition of the latest neonatal skincare guidelines came out, and that would be a great place to look at for information, as well as the EWG, or Environmental Work Group. They actually provide a database to identify toxicity levels of topical products. So, for example, Desitin has a toxic rating of 7 on a 10-point scale. So I think those are great resources. I also want to mention from a finesse standpoint that you always want to identify with your crucial conversations to know who your key players are. So with this idea of going green, it might be the pharmacist, the CNS, the NNP, the doc, the nurse manager, infection control, all of the above. This chain of command is important, of course, and it can take a long time to follow the chain, but you need to do that along the way. I also want to mention that it might be a great idea to find a friend in sourcing. So sourcing at every hospital is really responsible for finding products for the least amount of money that functions. And so keep in mind that, you know, their job is to find something inexpensive. And so really helping them see your lens and how important it is to be able to be green, I think is totally important. So the next myth we're going to discuss, I kind of put 3 of these together because they all really have to do with sucking and wearing a baby out or inhibiting breastfeeding. So the myths are using a pacifier will negatively affect breastfeeding, that sucking on a pacifier before feeding will tire a baby out, or that non-nutritive sucking wears babies out. So let's look at the evidence. Say and colleagues in 2018 looked at the effects of pacifier use on transition time from gavage to breastfeeding in preterm infants. Now, this was published in Breastfeeding Medicine, which is really great because they're dedicated to trying to help with breastfeeding. And it was a randomized controlled trial, single site of 90 preterm infants under 32 weeks. They had a control group that, of course, offered no pacifier because it was a baby-friendly hospital. And then another group that was offered a pacifier 4 times a day during gavage feeding and post-feedings for up to 15 minutes. The results indicated that the time to full oral feedings, the time to full breastfeeding, and time to discharge was significantly shorter in the pacifier group at a 0.05 p-value. And for all of these studies, I'm just going to say that unless I mention otherwise, the p-value is less than 0.05. So in this study with they also found significantly less gastrointestinal mobility and distension issues in the pacifier group. Likewise, Kaya and Attikin in 2016 looked at the effects of pacifier use on the transition to full breastfeeding and the sucking skills in preterm infants. And this prospective randomized controlled trial of 70 infants had 2 groups. The experimental group received a pacifier before and during transition to breastfeeding, and the control group received no pacifier. These results showed that the transition time to full breastfeeding and discharge was shorter in the pacifier group at a 0.05, once again p-value, and that the sucking skills of the infant in the pacifier group at 48 hours after transition to oral feeding and before discharge was actually better than in the control group. So these studies certainly support that feeding infants can benefit from a pacifier, or non-nutritive sucking more specifically. I also want to mention Foster's Cochrane review in 2016. And in this review, there was 12 eligible studies with a total of 746 preterm infants looking at the results of non-nutritive sucking on the transition time to full oral feedings. And they were able to identify that non-nutritive sucking provided a reduced transition time to full oral feedings, reduced time from start of oral feeding to full oral feeding, and a reduced length of hospitalization. Pasadopoulos and colleagues in 2015 published in the Iranian Journal of Pediatrics, and it was a randomized study with 26 to 32 week infants in 3 groups. The pre-feeding group received pre-feeding oral stimulation. There was a non-nutritive sucking group, as well as a control group receiving neither non-nutritive sucking or pre-feeding oral stimulation. The results identified weight gain at discharge in the non-nutritive sucking group was significantly higher than the control and the pre-feeding oral stimulation group. Once again, p-value of 0.05. Tian's group did a meta-analysis looking at oral motor interventions in 2015 in the Journal of Medicine. And this meta-analysis included 11 randomized controlled trials with 855 patients. Now, they defined oral motor intervention consistent with non-nutritive sucking, oral stimulation, and oral support. And the results found that this oral motor intervention reduced transition time to full feeds, increased feeding efficiency, increased oral intake of milk, and reduced length of stay. Likewise, Song and colleagues in a February of 2019 had a multi-centered randomized controlled trial of 210 preterm infants. And these infants were 26 to 30 weeks gestational age, and 2 groups focused with a pattern frequency modulated oral somatosensory stimulation, which is PFOS group, and that came through the pulsated pacifier through the N-trainer system, and then the control group received the passive non-nutritive sucking via regular or non-pulsating pacifier. And the results indicated that the infants with the pattern frequency modulated oral somatosensory stimulation actually had a reduction in time to full oral feeds with the p-value of 0.3, and the 29 to 30 week subgroup had a reduction in time of discharge at a p-value of 0.01. the finesse. I think it's important for us to really identify in our crucial conversations about non-shift sucking really not just being about feeding. And in fact, it's really about the ability for it to offer homeostasis. When we think through Dr. Heidelise All's synaptive theory, looking at the autonomic, motoric state, attention, and self-regulation, it's important to identify that all neonatal therapists should understand that this non-shift sucking is number one for self-regulation. So I'm going to show this video of this baby who's got an increased heart rate, motor stress, crying, state stress, and simply by providing a pacifier for non-shift sucking, this baby's heart rate returns to baseline. The baby has reduced motor stress, is able to keep a quiet alert. The next myth we're going to debunk is that starting oral feeding earlier will help a baby get to ad-lib feeding sooner. I mean, I'm sure that seems logical that if you start a little bit earlier, the infant will get to feedings and go home earlier. But let's look at what the evidence suggests. Wang and colleagues in 2018 had a study in the Journal of Nursing Research, and they had randomized controlled trial with 40 infants less than 32 weeks, and they looked at two groups with the effect of delayed start of oral feeding on feeding performance and the physiological responses in preterm infants. So the control group had feeding started when the baby was physiologically stable and the feeding cues were present, and the experimental group started feeding the baby 7 days after the baby was physiologically stable and cues were present. The results indicated that the post-menstrual age at full oral feedings, that weight gain and feeding performance was actually the same for both groups, statistically significant at a 0.05 p-value. The transition to full oral feedings was significantly shorter in the experimental group with a p-value of 0.03, and that's not a surprise because they started a minimum of 7 days later with oral feedings. And so like we said, the post-menstrual age for full time to oral feeds was the same. So the control group had more oxygen desaturations during feedings, and I think this is one of the more critical parts of this study because when fed as soon as stable at 32 weeks, they had more physiological issues. Now, Pickler and her group looked at this more specifically in 2015. Their randomized experimental design with 86 preterm infants under 32 weeks were divided into 4 groups. So group 1 was an early start at 32 weeks post-menstrual age, and they slowly progressed with gradually increasing feedings offered, once a day, once a shift, every other feeding. And then group 2 had an early start, which was at 32 weeks post-menstrual age, but they had maximum oral experience, meaning that they were offered oral feedings every time there was an opportunity. Group 3 had a late start, which was at 34 weeks post-menstrual age, and did that slow progression, whereas group 4 started at a late start, which was 34 weeks, but had the maximum experience, meaning they were offered the feedings every feeding. The results identified that it was actually the group 4 late start maximum experience that achieved full oral feedings and discharged home significantly sooner than either early start group. And this was a p-value of 0.01. I think this goes back to the importance of looking at, that autonomic stability, and that it's not just about feeding, but looking at the big picture. So when we look at the NICU environment as well, and the bigger picture of oral feeding, that's not just about the gestational age or their weight, but feeding is a neurodevelopmental journey, and that it requires them to have adequate behavioral state and be able to keep an alertness and have organization between those states. And I think parent education is vital in all of this as well. just having a baby eat their feeds is not significant for going home. The mom or the dad or the caregiver also has to be able to help their baby eat. And so parent involvement with direct breastfeeding, for example, starting at that 32 weeks, and if the baby's desatting a lot and just not really doing well, I feel like it's so much more likely that the mom's just going to give up on breastfeeding. Whereas if we start them a little bit later, and in this study it suggested later with the cues and physiological stability actually did better when starting closer to that 34 weeks. And it's really why in infant-driven feeding, the original concept was to look at cues starting at 33 weeks so that you can identify really where these babies were at with the ability to orally feed. The next myth that we're going to look at then is one that actually made me laugh out loud when I realized it was still a myth today. And it's that slow flow nipples wear babies out and make it harder to progress to ad-lib feeds. So I've been practicing for what now, 33 years, and I feel like this has been a conversation since the beginning of time. And when you look at the research, there's been a lot of studies. And in fact, as we look at the evidence to debunk this myth, I intentionally left a few that were really old because it shows that we've had this information for quite a long time. So this first study with Lau and group was from 1997. That's a long time ago. And it was in Journal of Pediatrics. It had an experimental study of 26 to 29 week gestational age infants that ate from an adapted bottle nipples for unrestricted or restricted milk delivery. So the results show that there was a significantly slower oral feeding progression if initial feeding had lower proficiency, efficiency, or both. And this really speaks to the starting too early part as well that we just talked about in the previous myth. But they learned that the restricted milk flow facilitates oral feeding efficiency, proficiency, and overall transfer. Likewise, feeding proficiency and efficiency may be used as a reliable indicator of early attainment of independent oral feeding, was also identified in that study. So literally, fast forward now from 1997 to 2007, and Cheng did a study where they looked at the effect of a single hole or cross-cut nipple at looking at feeding efficiency and then the physiological parameters. And so this crossover design was interesting because they had 20 stable infants at 34 weeks post-menstrual age, plus or minus 1.6 weeks at the time of study. And they fed with equal feeding amounts using a single hole and a cross-cut nipple in a random order. The results found that the infants with the feeding with the single hole nipple, which means a slower flow, showed an increased overall intake, shorter feeding time, and more feeding efficiency, whereas those feedings with the cross-cut nipple, or therefore a larger flow, showed higher respiratory rates. Now, I don't have time to go through all the articles that were also going to be in the supplementary handout that you're able to get from us. But in looking at all of those studies, there was evidence to show that when milk consumption is low, the sucking to swallowing ratio increases, conserving ventilation, and that lower sucking pressures were noted with high flow nipples as compared to the low flow nipples, which of course is important for long-term feeding success. And then that there was decrease in minute ventilation and respiratory rate was greater with the high flow nipples, and that the high milk flow also contributed to reduced ventilation during nipple feeding. So I think all of that is so important because this whole suck, swallow, breathe pattern is so integral to long-term feeding success. Afterwards in transition to sleep. So it really kind of emphasizes that non-nutritive sucking is important way outside the feeding realm because it provides homeostasis, which is really what all of us are trying to identify anyway. So from a finesse standpoint, I think it's important to know that there are a lot of ways to control the flow, and certainly not just by the bottle nipple selection. For example, the positioning of both the infant and the nipple can affect control. So if you position the nipple, for example, on the tongue and it's very anterior, the tongue will just get a little flicking motion. You'll have a lot of anterior milk loss. It looks like the baby's eating and getting too much because it's flowing out the front, and you'll want to have a tendency to get a slower flow nipple because you think they're losing a lot. But really, it's just about the proper placement of the nipple needing to be more posterior and superior to allow the tongue to come forward and underneath to draw the milk out. And then also in terms of just the infant's body position affecting the flow management, certainly if the head is very posterior in that occipital extension position, it makes the mouth hang open and the baby's literally trying to just not aspirate the milk because the head is back in an open airway position. And this sometimes happens from those neck rolls that we use for long periods. The trapezius gets tight, the scalenes get tight, and it makes it difficult. So they don't need a slower flow nipple. They need to have some manual therapy to help put their head back in alignment and potentially not have used the neck rolls as much. Likewise, just looking at that autonomic stability, I just want to come back to that again and looking at the synactive theory and making sure that we're paying attention to the motor signs, the state sign, the attention, the autonomic, and all of those signs that are helping us identify that the baby's saying, hey, I'm getting tired. Hey, I'm not hungry anymore. Hey, I want to eat. And all of that, there's more to feeding than just the mouth for sure, and certainly more than just the flow rate. But in terms of knowing the flow, once again, I'll just refer you back to that Patos article in 2019 that is in your supplemental handout. So this brings us to, since we were just talking about positioning, another myth, which is feeding a baby upright is better than sideline. So when looking at the evidence for this, we can look at the reference from Gurgen here that's in 2018, and it was a randomized controlled trial with 80 infants born under 31 weeks gestational age, and they were divided into two groups. So group 1 was fed in a semi-elevated sideline position, and group 2 was fed in a semi-elevated supine position. And the results showed that those semi-elevated sideline had both higher SpO2 values and lower heart rates during the feeding. And that the semi-elevated supine group had more oxygen desaturations and increased heart rate. And you can see the p-values there. Park's group in 2014, then in the Journal of Perinatal and Neonatal Nursing, their study looked at a group 1 and group 2 in those same kind of feeding categories, and their results showed a semi-elevated sideline position had less variation in their heart rate, less severe and fewer decreases in heart rate, and also less respiratory rate, which remained closer to the baseline. So from a Finesse standpoint, I think these pictures kind of say a lot, just in realizing that we've been feeding, from a breastfeeding positioning standpoint, that's been sidelined since the beginning of time. So it's interesting to think that we think of normal not being in sideline position when in fact it really is. And then also just realizing from a sideline feeding position, it also decreases that hydrostatic pressure generated by the volume of milk in the inverted bottle. So these are all things to have those conversations with some of your peers with as needed. This position also keeps the tongue from being affected by gravity and pulling it back. And so it also, from a functional ability to coordinate the suck, swallow, breathe, it certainly makes that a lot easier as well. So lots of little easy conversations to have with your peers. This last myth is one that I've spent the last 10 years trying to address, and one I'll spend the next 10. And it's that neonatal massage is just something nice to do. So in terms of the evidence, there's two great meta-analyses that have been recently done. The first one, Cordero from 2019 and colleagues, looked at better weight gain, decreased length of stay, improved parasympathetic responses, and then increased cell cytotoxicity of the natural killer cells. So keep in mind that a meta-analysis is the top-notch in terms of research. There was another one, Alvarez in 2017 with his colleagues, looked at improved weight gain, better neurodevelopment, reduced length of stay, and improved PNS response. So really when you're looking at these two meta-analysis, it's debunking that myth right away that massage is just something nice to do, because it has all kinds of developmental and medical benefits. Some of the other research then that is just as important, Alvarez in 2019 showed that there was improved weight gain, length, head circumference. I want you to notice the p-values on these studies to the right. Reduced serum and transcutaneous bilirubin, that p-value is 0.00001. So clearly, if you provide some massage in those first 4 days of life, you can change your TCB results. From a PIP standpoint, or the premature infant pain profile, you've got decreased pain scores in 2019 with massage shown by Motter. And then lower cortisol levels in 2020. So that was just done this year as Marani did that one. The improved sleep that was done in 2019, one of the things that was kind of cool about that is that the infants received massage 3 times a day for only 5 minutes for 5 days. And they had the improved outcomes and improved behavioral responses before and after massage then. So that was a cool one as well. From a parent standpoint, there's certainly a lot of different benefits for parents doing massage. This one that I've got on here from 2017 by Shogi and group was one that looked at showing a statistically significant difference between the baseline and post-intervention when massage was provided. And basically the conclusion was that massage given to premature neonates by their moms on a daily basis can really promote and maintain emotional attachment for the mother and infant, and that we should be even looking at studies to see if other family members can do this as well. In terms of the finesse with neonatal massage, I think first and foremost, and I could talk about this for the next hour, but it's about doing with, not to the baby. The idea is not that we're just going to go and do massage 15 minutes 3 times a day, and you learn these strokes and you're doing it to them. And so there's a skill level and there's a whole mindset with this that training is required to be able to learn the cues of the baby to do it with them. And then looking at that just in terms of being a goal-directed intervention. Once again, it's not just a task that you're doing in your day that you're going to check off a list for, but a very intentional intervention in providing for a baby. And that you're going to include that positive touch, even when you're doing something like taking a temperature. So you can see this person is providing that gentle human touch, that positive touch while she's taking a temperature. And so that training and developing the skills to be able to incorporate this neonatal massage is very important. And then the other thing with the finesse of this whole massage thing is starting small and then go big. So I think when after you're trained, you want to start small and looking at the babies that are at lower risk and developing that trust and developing your skill, and then really developing a program, a massage program in your nursery where you're teaching parents on a regular basis and the rest of the staff and really changing the culture, whereas neonatal massage is part of the regular care for babies in the intensive care unit. So we spent the last hour or so just talking about really ways that you can help change your culture by debunking some of the myths that occur. And I love this. Rear Admiral Grace Hopper said, the most dangerous phrase in our language is, we've always done it this way. And so I think when we hear that, we want to spark some ideas in our own mind of how we can have some crucial conversations and change perhaps in a more evidence-based way the way we care for. And in doing so, I just want to bring you back to this Simon Sinek book. And so Simon Sinek has done lots of TED Talks, and you can, this book is from 2009, but he has continued to really set the pace out there. His book, Start with the Why, How Great Leaders Inspire Everyone to Take Action. And if you look at this core, we don't need to tell our healthcare providers what to do or how to do it. We need to start with the why, because if they understand that, for example, neonatal massage can change who that baby is and that they can get home quicker, and that having a mom learn massage for their baby can change that relationship forever, then they'll be more interested in learning the how to do it and then the what. So start with the why, and I think that's important in debunking any myth, is starting with the why. So as we wrap it up here at the end, Shannon, I just want to thank you so much for listening, and want to remind you also that there's that supplemental handout. If you're interested, just go to this site here, creativetherapyconsultants.com/debunking myths, and we'd be happy to email you a handout that will actually provide all the myth, the evidence, and the finesse comments about it. And just keep in mind that we have a lot more evidence on the handout than what we could present in this quick little talk. So we are happy to answer questions now.
Thank you both so much. That was really terrific. There's also a great bibliography at the end that when you download the handout, you'll be able to have that as well. But I just wanted to show you my book, Start With Why. Interesting. It's one of my favorite books and one that I use for my work a lot. So we are going to open up for questions now. Shannon and Kara Ann are both on. Kathy Randall's going to help out with the questions. So just please type them in the Q&A section, and we'll answer them in the order that we get them.
So let's start with the one that kind of came in really early. And so Brenda, thanks for this one. And it was really about how important it is the direction the baby's facing during side lying. So should they face the caregiver, parent, therapist, or can they face the other direction? Oh, Kara, you're still muted.
Can you hear me now?
Yeah, perfect.
So great question, Brenda. And really it's the idea that if this baby's side-lying, this baby also is having a little bit of a harder time coordinating sex, swallow, breathe. And so to add another visual input of a person's face sometimes is too strong. And we know babies are so social and be like, oh, hi, are you my mommy? And they completely stop breathing or eating. So I think it's important for the caregiver to be comfortable. It's difficult sometimes for us to put a baby in side lying and have them turn so we can see them and have that face-to-face interaction, which isn't always necessary during some of this time. I think it's really important to have that face-to-face time, but maybe not when they're actually oral feeding at that time. And as the baby gets more mature, obviously, they can handle more and more of that.
Great. Let's looking through, I know a couple of you had some questions about just the statistics. There was, oh gosh, it's right near the end, a p-value difference.
Yeah, let me address that, Kathy. So if you go into the answered questions, because there was a question.
Okay, great.
P-value that I actually just had a typo in the slide. I verbally said the right thing. It was
Got it.
0.05 and 0.03, but it's a typo we left out a 0. So just keep in mind that that information is correct on your supplemental handout for sure. And I guess at that point, listen to what I say and not what I showed you, because it was just wrong. And I was so glad that she pointed that out to me. So Karen, thanks for that.
Yeah, I'm sure it'll show up in, like you said, in the other handout. Question on how do you transition from slow to regular flow nipples? Any tips on how you make that transition?
I think it's all about the baby. Reading infant cues. You know, when the baby is successfully eating with a slower flow and not having any problems and not having A's and B's and the eyebrows aren't going up and she's not doing this or choking or coughing or sputtering, it might be that somebody wants to trial that, you know, faster flow nipple. I think it's a myth to think that we have to leave the nursery on a nipple that is not slow flow. And so if we have to go home, I'm just making this up, on a Dr. Brown's preemie nipple, you know, that's okay. They don't have to be able to transition to a regular level 1 nipple. That being said, I do feel like then we want to make sure that we've got some substance for that family and caregiver to know if they're going to do that at home, how should they do that? So it's all about teaching the family and the caregivers the infant cues, and then when to transition becomes so much easier.
Excellent. Shannon, anything else you want to add?
No.
Cool. There is some kind of just validation people are asking for about lactation, who sometimes are lactation consultants who work across multiple different areas of the hospital, quote unquote, love to tell moms that pacifiers lead to nipple confusion. So any additional comments you'd like to make about that?
I think, you know, honestly, it kind of goes back to the intent of the caregivers that we work with, is that they really just want to provide the best care and the best information. And at some point, those lactation consultants were taught that. they were taught that pacifiers interfere with breastfeeding. And so they're just oftentimes uninformed that we now know that that's not what goes on. And so it's about educating them and having those conversations, and also recognizing and teaching our lactation consultants those same cues for hunger, recognizing when a baby's hungry. You know, so often we don't want to give a baby a pacifier because it masks when they're actually hungry. And so balancing that, understanding the baby, understanding the difference between needing non-nutritive sucking and the support to self-regulate, and when I'm hungry and I need to eat. And so, you know, that discrepancy is really important.
Great. Kara, anything else?
Well, I just want to say that it's so doable. We just have an awesome relationship with our lactation consultants at one of the facilities I work at, and they're just awesome because we've collaborated together, we share research, and I think it just puts a plug out there. Somebody needs to, we all need to remember that we need to look in multiple journals. If we're a nurse, don't just look in a nursing journal. If we're a therapist, don't just look in a therapy journal, and same for lactation. And I think it's also important for us collaboratively to publish in some of those lactation journals as well. If that's where they get most of their stuff, then I think it's all about sharing the wealth of information that we have.
Absolutely. So Christine's saying, and I'm assuming, Christine, from what I'm reading between the lines that you're a therapist. And so it says, you know, sometimes you come back after a weekend and a nurse will have trialed, say, a faster flow nipple based on what they've observed with the baby. And it's either sometimes great and sometimes not. And then that's an opportunity to have a conversation with the nurse and the family. So, you know, maybe using some of those crucial, you know, conversation tips that you gave us, how should somebody approach this?
I think, you know, that's something that we all see all the time, you know, and I think it's important that as, you know, caregivers, we give that, that autonomy and that self awareness to make a transition based off of what you're seeing in the moment, because that is really important. And what's transpired over 48 hours in the nursery can be significant. A lot of things do change in 2 days' time. So having that respect for your coworker or your peer to, you know, say that, you know, you understand that that was why that choice was made in the moment. And then, like you alluded to, Kathleen, utilizing those concepts to have that conversation and, you know, developing or, you know, having respect, you know, recognizing that, you know, we may have some resistance to it or that people may get defensive, you know, again, those physical signs, you know, people just oftentimes in those difficult conversations don't act the way that they normally do. And so just being aware of that and helping them to problem solve together.
And I just want to add to that, I think sometimes too, like as a therapist, we haven't maybe educated the people who just work on the weekends or
Right.
the shift people. And so it's really about, you know, sharing our lens. And if we see something through this lens of research that we now have the opportunity to have read and understand, then we need to make sure that we have provided that same visibility on those off shifts and help establish those relationships and have those crucial conversations instead of just Monday morning at 6:30 a.m.
Excellent. So there's kind of 3 overlapping questions around GERD. And so I'm going to kind of try to combine them all, and then maybe you guys can pick it apart. So one is just overall best position for preventing reflux. The other is for the babies who have reflux, do you do left side lying when they're sleeping? And then the other is if there's not a parent available, do you go ahead and leave them prone for 30 minutes and then supine if they're in their bed? Do you leave them flat during gavage? So outline it all.
Gosh, those are great questions. And I feel like, you know, gastroesophageal reflux disease is this never ending, you know, overarching thing that we all have these conversations about.
Yeah.
And, you know, who knows if that problem will ever be solved. You know, I would encourage you to look at the Committee on Fetus and Newborn article that we had included that just kind of really does a nice job summarizing what is it, what does it look like, what does it not look like, what do we think it looks like, and what can we do about it. You know, I can, you know, speak to anecdotally in all these different articles, but I truly think that that's a great summary for you that would just give a lot of powerful information and really go to the experts on that. You know, I want to provide you with the resources to get the true expertise on where you should go with that.
Excellent. Kara, anything?
Not at all. I just mentioned, I think somebody had a question about, head of bed and what about if they have VAP?
Yep.
Just your VAP protocol. So keep in mind, ventilator-associated pneumonia, for those intubated babies, if your hospital has a protocol of keeping a baby elevated for, 30 degrees or 15 degrees or whatever the baby's intubated, then that's about a VAP protocol. That's not about a GER protocol. So I think we just have to also realize that now that baby's not been on oxygen for a long time and we're still standing them up. So just kind of, following the policy truly what it says and not just kind of having a generalized everybody's elevated all the time.
Right, right. Let's see, I wanted to go back to, so you're recommending the fetus and the newborn guidelines for that. So let me just answer this one. So we're good there. So Isha, I'm gonna not answer that one because I think that's more of a respiratory question, and I'm not sure that Kara Ann, you guys, again, I think I would follow what you just said, which is, there are different rationales for the positions, for the different baby positions and conditions, not to have a rhyme, but I think, how to do that, let's lean on our respiratory colleagues for kind of best practices around that head of bed elevated for various respiratory situations. Let's see, let's go back up to the question around massage and the use of oil during massage and contraindications or benefits or risks associated with using that when the babies are under phototherapy.
So that's a great question because even in our neonatal touch massage certification for years, we have just had that as like a little caution if the baby's under Billy lights to be careful because keep in mind I'm old. And so back in the day, the bilirubin lights that we had, it was like putting, baby oil on a baby's skin. We didn't use baby oil, but same thing. It's shiny and then, oh, we're going to give a sunburn. Now, the beauty of it is technology has caught up with us. And so since that time, we've been assured like that for example, the blue lights, for example, don't have that problem anymore. And so I think definitely we can be less cautious about it. I still like to keep it in my caution, my protocol for the hospital to just have everybody think through that. Because what I also know about hospitals is we might have 10 new Billy lights, but when we have an increased census, we go to the bowels of the hospital and we pull out that old bank of lights that has been sitting down there. And now it's the kind of light that's not okay with that oil on the skin. So it's about knowledge. It's about awareness and just knowing that when we do that, we just make the right choices at the time.
Excellent, excellent. Oh, now they know that their questions are like rolling out now they're here. So, let's see, what can we do for babies who just keep desatting and holding their breath no matter what you do, whatever, you've tried every nipple, they've listed like 7, and what do you do for those little ones?
Well, I think my first question would be is, do they desat when they're not eating? Do they have sleep apnea? Do they have periodic breathing? Do they, so it's all about that homeostasis before feeding. If in fact they're having all of these issues, and then we're trying to put in aerobic activity that requires 26 muscles and 6 cranial nerves to do a sex swallow, sex swallow, sex swallow, breathe, then sure, I can see that being a problem. It might be that maturationally they're just not there. It could be that they have an airway disease. I mean, I think that is such a great clinical question about a specific clinical baby. So I didn't see who that was, but certainly reach out and we can have a conversation more intensely about a specific clinical decision based on that baby and who they are. But in general, a baby that's having that many problems orally feeding, I think you mentioned even with the slow flow, then it just makes me wonder whether we should be doing that at all.
They're really safety first.
Correct, always.
It sounds like Maribel, you're following up and saying it's happening only during feeding, but if I was you, I would take Kara Ann up on her offer and contact her. What a fun opportunity. Okay, with regards to pacifiers, I'm just trying to, this is kind of a long one, so I'm trying to, could we agree that it may be preferable to utilize holding to console a hungry baby while waiting for mom to come just prior to breastfeeding? As my experience, a pacifier just prior to breastfeeding makes breastfeeding harder and the latch, so especially during the early. So I guess it goes back to that use of non-nutritive suck and what you think is the best practice if they're consolable, I guess.
Yeah, well, I think part of it is just the underlying knowledge and understanding that when we, tell a mom that the baby eats at 9, 12, 3, 6, she's going to show up at 9. And really what we want to do, and knowing that she's got to park the car and she's got to walk through the hospital and then the baby's awake and active. Keep in mind that if a mom who's breastfeeding holds that baby 20 minutes prior to breastfeeding, all that hind milk comes down. And when that hind milk comes down, now that baby's getting that really rich, awesome milk. And so if she could do skin to skin for the 20 minutes before, if she can come at 8:30 and do skin to skin prior to, and then when she, latches on, that baby's getting that great milk. I think part of that whole, holding a baby off is partly because we tend to give time frames like, come at 9 o'clock, when in fact, it'd be really awesome if they could work it out to come earlier than that. And then beyond that, obviously, we can use all kinds of other calming techniques that we teach, whether it's that frontal pressure, flexion containment, alignment and comfort, some, vertical rocking, all those other kinds of things. If you're not comfortable with that pacifier, I would always dip that pacifier in that baby's mouth. Dip the pacifier in the baby's milk, the mom's milk beforehand. And honestly, if it's a breastfeeding kid, use your gloved finger. Put it in the breast milk, keep that baby happy with the gloved finger before the mom comes in to put him on the breast instead of using the passy.
And the only other thing I would add to that is if you're holding that baby and they're comfortable and happy and content and self-regulated in your arms, then they don't need the pacifier anyways. But if you've got a baby, so from an energy perspective, but if you have a baby that's in your arms that you're rocking and you're trying to move around and you're just trying to hold off for feeding and not offering a pacifier, realistically, the amount of energy that would be burned with that type of state and activity level is more than they would being calm in a quiet, alert state, sucking on a pacifier. So if just from an energy expenditure standpoint, that if you're able to get them to self-regulate without a passy, awesome. But if you're just trying to do that, a pacifier would use less energy anyways.
Great point.
Awesome. Well, I think that's the end of the questions, and I'll post up the evaluation for those of you who want at least either a nursing CE or they want the participation link. I also reposted the handout. Somebody asked about that.
Super. And just to follow up, in order to receive the free CE, you'll have to follow the link that Kathy's going to post and fill out the evaluation. If you're watching the recording, please go back to the email you received with the link to the recording and click on the link to the evaluation form. If you will receive an email with a PDF of your CE certificate within 24 hours after you fill out the evaluation. And be sure to check your spam if you don't receive the email within 24 hours. We've had trouble with that. If you are watching live and don't have time to fill it out right now, or your hospital has blocked access, don't worry, you'll get that email in the next day or so with a link. And one important thing, if you're viewing as a group, each of you must log into the evaluation to get the CE. So we hope you will like DandleLION Medical and our webinars on Facebook or LinkedIn, and you'll also, by going there, be the first to find out about what's new at DandleLION Medical. We are getting ready to launch something exciting. We are going to be offering virtual positioning labs for new and experienced DandleLION users. There'll be an opportunity in the evaluation to let us know if you might be interested in attending any of these free labs. Also, just a reminder to visit our website for links to the recordings of our previous 3 years of webinars that are still active and available for our continuing education credits. So thank you all for coming, and thank you, Kara Ann and Shannon, so much for a wonderful, wonderful, multifaceted webinar, really. I mean, a lot of great interpersonal information and dealing with crucial conversations, and then debunking a lot of great myths. As always, you guys are very evidence-based, and we really, really appreciate that. So thank you both. Thank you all again, and we'll see you in a couple of months for the next DandleLION webinar.
Thank you.
Thanks, ladies.